Hey Isaac, are you there?
Yeah, I'm here, but I'm on a phone call, so just give me 1 second.
Oh, that's okay. You don't have to put your camera on yet. I'm just going to mention that I'll do like 10 or so minutes just to present the regression stuff before I hand it over to you.
Okay.
And then hopefully everybody's read the, the article. I did go onto the clinical trials website this morning and I can see it. I can see that it's registered there. And it looks like they had powered it like ahead of time, thank God. So they just weren't very clear about that in the manuscript. And then they powered it to show non-inferiority. So essentially what they're doing is showing that, one intervention is no worse than the other. Like they're not doing it to show that one's better than the other. Does that make sense?
Yeah, so it's a non-inferiority. Basically, they're trying to sh it's not better, but it's not worse at the same time, basically.
Yeah, because it changes the stats in the background if you try and power it to make something look better. But now, like we've got interventions for so many things, we're not really showing, oh, this is better than nothing. We're trying to show that maybe this new intervention is no worse than what we currently have, but maybe it's got less side effects, maybe it's more, people are a lot more likely to be adherent to it, things like that. Um,
Okay. Because I think that was one of the things that they were trying to do with the secondary endpoints. Like, apparently, patients preferred the positional therapy over the CPAP, but that's if they tried it first. But yeah, I'll get to that when we talk about it.
yeah. So I didn't see, did you see it in the article that they'd powered it for a non-inferiority trial?
I did
I didn't
not
see
read
that.
those words, so I
Yeah, I
remembered,
didn't
yeah.
see it either.
It would have been nice if the actual article mentioned that.
Yeah. Yeah, so I just saw that on the clinical trials website. That's where I saw it.
So they got the trial site back up because like I was like typing it in and it
Yeah,
kept saying the site is down since February
yeah. I just
28th.
thought I'd look, a few hours ago just to see if it was
I
back
guess they
up and
did
it
bring
was
it back
there.
up.
Yeah. So at least we know that they thankfully powered it ahead of time, but they just weren't clear about that.
Yeah.
I don't know if people are in clinic today,
Uh Technically since I'm in
You're not
California,
there. I know you can't see, right? Because you're not there.
but I think half of them were with reading studies today and there may have been one or two that were in a different location. I know one of them's in the VA.
Okay. We'll maybe like give it a couple of minutes after the hour for people to finish up. We'll give it another minute, and then we'll get going because I don't want to take time away from your presentation. I think we're getting most of the fellows. So I might just share my screen. Can you guys see that?
Yep, we can see it.
Yeah, okay, great, thank you. All right, so I'll get started. I can't see like who's on because I've got rid of my camera just so I can see the page. But feel free to stop me because I won't be checking the chat. But this is just going to be 10 minutes of a very high level overview of regression analyses because you'll be seeing these in the manuscripts that you read or present. So it's just important that you understand the bigger concept. So many of you may know this, I don't know. Some people do, some people don't. But just to say that, you would use regression when you want to see if one or maybe more variables are associated with a particular outcome. And so you will probably be familiar with a couple of different types of regression analyses. And the reason that we have these two main ones is because it depends on how your outcome is characterized, right? So I've color coded them just to try and, keep you focused on which one we're talking about. So anything in red is going to be a linear regression, and anything in blue is going to be a logistic regression. So in terms of when we use one or the other, just think about it in like a simple term that if your outcomes, if the thing you're interested in finding out about is continuous, like a blood pressure reading or a glucose level or a BMI or whatever it is, if it's a continuous variable, then your regression will be a linear regression. Okay, that's the red one. If, however, your outcome is dichotomous, so it's, a disease is present versus absent, it's a yes, it's a no, then you're looking at a logistic regression. So just look at that outcome, figure out if it's continuous or dichotomous, and then you straight away should figure out, which regression we're dealing with. So let's talk about the red, which is the linear regression for a moment. Well, here, before I do that, we can see these are outputs that you'll see. I'm not going to go into detail on these, but you will see in various outputs from statistical software, you'll see beta values, which is the direction, like positive or negative, and the magnitude of the association with your outcome. You might also see confidence intervals and p-values. Okay, so linear regression. So let's think about a really simple linear regression. It's actually a correlation, right? We all know what correlations are. They tell us the strength of the relationship between two variables, right? You can see three different sort of patterns here. But essentially, a correlation analysis is a really, really simple regression with just one predictor variable. So in that first panel, you can see here, it's a negative association, right? Because it's going down. The middle one is a positive association, and then we've got no association in that third panel. So that's kind of a real simple regression, right? A correlation is a real simple regression. So how do we interpret them? So we can interpret them by thinking about whether your predictor variable was continuous or it was categorical. Okay, so if it's continuous, what that means is that for every 1 unit higher in your predictor value is related to whatever your beta value says in your outcome. Okay, that sounds a bit complicated, so let's just sort of give an example. So if we were looking at BMI as predicting blood pressure, and we saw that there was a positive association and the beta value was like 2, that would mean that for every 1 unit increase in somebody's BMI, there is a 2 millimeter increase in their blood pressure, 2 millimeters of mercury increase. Okay. If, however, the predictor variable that we're looking at is categorical, right? So that means that being in one category versus the other is associated with whatever the beta value is of the outcome, okay? So again, let's just walk through that with an example. So when we're talking about BMI, instead of using the units that we do in the first example, we're going to use overweight versus not. So a category yes versus no. So in this case, we could say that people in the overweight group had a 5 millimeter, because 5 could be the beta value in this case, had a 5 millimeter of mercury higher average blood pressure than those in the normal weight. Okay, so essentially, even though your outcomes can be continuous and your outcomes can be categorical, so can your predictor variables. Okay. So when we think about regression, we go beyond a little bit that correlation, that very simple regression, and we add other variables to the model. So essentially what we can do is look at a predictor, let's say, of BMI on blood pressure or weight category group on blood pressure, but we can adjust for other variables, right? So we can account for the effect of age, we can account for the effect of gender, we can account for the effect of, other diagnoses. Anything that you want to account for, we can do that. And that's where the regression becomes quite powerful, because it will take into account the effect of all of those other variables in our model and show us if the one we're interested in, like in this case, the BMI, is still predictive of our outcome of blood pressure. Okay. So let's switch to the logistic regression. So remember, logistic regression is when we're wanting to predict a dichotomous outcome. So our outcome is disease present versus not present. Okay, and then we can use continuous or dichotomous predictor variables. So in this example, if we use a continuous predictor and we're looking at sleep duration and the outcome being present, in this case, let's say depression or depressive episode. So if you're using a continuous predictor, what we will show is that for every 1 unit higher value in our predictor variable is related to a higher or lower odds of having the outcome present versus absent. Okay, so as an example, we might run a regression. We might see that there's a relationship between sleep duration as a continuous measure and the odds of depression being present or not. So here, this one shows that for every 1 hour greater average sleep duration, we get a 1.2 times the odds of a depressive episode. Okay. Now, our predictor could be categorical. So instead of looking at every hour of sleep duration, we could be in an insufficient sleep duration or a sufficient sleep duration group. Okay, so that would be our categorical predictor. We can still do that. We can put that in the model, where people in this group versus this group. And in this case, what we see is that being in the insufficient sleep category is related to a 1.2 times higher odds of experiencing whatever it is. In this case, I wrote heart attack. It could be depression, whatever your outcome is. Yes, no outcome. Okay. Now remember from our sessions a few weeks ago, 1.2 times higher odds is the equivalent of a 28% increase in odds. Remember? So let's walk through another example and see if you can see what I'm getting at with this. So let's say we did a big study, then we're interested in looking at maternal age and pregnancy outcomes. So we studied 7,000 women. We collected lots of variables, in particular age and birth outcomes. So we have their age, right, which is a continuous variable. We also can dichotomize it into less than 40 and greater than 40 to look at risks or odds of those different groups. So we have study questions. So question number 1, is maternal age associated with blood pressure? Okay, sounds pretty simple question. So let's just say we run a regression with our data and we get some results. And here we have a beta value. So in our results, it's a beta value of 0.27. So straight away, we should be able to tell what type of regression was used. So does anybody want to hazard a guess as to what type of regression must have been used if we have a beta value of 0.27?
Linear regression.
Exactly. Linear regression, because we got a beta value. So what would the interpretation be? So for every 1 unit increase in maternal age, so every year increase in maternal age, blood pressure would go up by 0.27 millimeters of mercury. okay, because that's continuous. We're doing a linear regression. So we could ask the same question in a slightly different way and say, is maternal age of 40 or higher related to hypertension? So we still do a regression, but this time, what would the regression be? And the clue is in the results. Well, the clue is in the question, I guess, but the results are going to be odds ratios because our outcome is dichotomous. So the
So
regression would be
logistics.
logistic regression, right? So does anybody want to hazard a guess on what the interpretation of our second experiment would be?
Is it for every like age over 40, there's a 23% chance higher relation to hypertension?
Exactly, a 23% increase in odds of having hypertension if you're over 40. Excellent. Yep. So those were simple ones. I got one more thing just to walk through with you, but we can add other variables into this model, right? So this one here is basically showing a regression of preeclampsia against maternal age, but this time we're going to account for other covariates, right? So we've got maternal age. In this case, it was done by increments of 5 years rather than just 1 year. BMI, gestational diabetes, chronic hypertension, tobacco use, and this being a first pregnancy. So what we see here is, yes, maternal age is increased, like, so the increase in the odds of preeclampsia, in this case, it's relative risk because it was a different study design, but the same point. There's a statistically significant increase in preeclampsia by maternal age. As maternal age increases, the preeclampsia goes up, right? You can see the p-value is statistically significant. But we also see that there are other things that are statistically significant. So essentially, what this is saying is that even after we've accounted for all these other variables, the effective age on preeclampsia is still statistically significant. We might have other things that are also statistically significant in the prediction of preeclampsia, but we were primarily interested in age, and that one still holds. Sometimes what you'll find is if we just looked at age in preeclampsia and we found that it was significant, once we put other variables into this model, maybe the age no longer becomes statistically significant. So that's the beauty of these regression models, is we can test that after we've accounted for a whole bunch of things that we know are related to our outcome, is our variable of interest still significantly predictive of our outcome? Okay, so like you can see here, chronic hypertension is 5 times. When you look at the preeclampsia, you got a 5 times increased. In this case, it was risk of preeclampsia, even after you've accounted for age, BMI, diabetes, blah, 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 all the rest. Okay, so it's quite a powerful tool to use, and just kind of having a general overview and understanding of, I think regression is a good thing to have when you're reading these and presenting these articles. So I will stop there and I will hand this over for our journal club.
Does everyone see my screen where it's like
Yeah,
not
we
in
can see.
presenter view? Just making
Correct. Yeah,
sure.
we see it. Yeah.
Okay. So I picked this article called Prospective Crossover Trial of Positional and CPAP Therapy for the Treatment of Mild to Moderate Positional Obstructive Sleep Apnea. So I picked this article because it highlights a lot of the importance of offering like alternative treatment options for mild to moderate positional sleep apnea. So it allows them to like kind of have a choice in their therapy. Uh, Mainly because it does compare like positional therapy and CPAP, and ultimately trying to show if both therapies provide significant symptomatic improvement. They measured like endpoints like sleepiness reduction, sleep efficiency, patient preference, and the study kind of focused on outcomes that mattered, like apparently it said most to patients. So it may help with more personalized treatment approach in OSA. So just a brief like on the study design and methods. Uh, all the participants in the end they had were only like 52, and they were treatment naive, so they never been on any treatment before. They were symptomatic, and they had to have mild to moderate positional OSA, which we'll get to in the next slide. They did a prospective crossover randomized controlled trial, and then the intervention was they were trying to have an in-lab treatment initiation with PSG to see if positional therapy or CPAP on subsequent nights, and then they monitored over an 8-week period, and then they made them flip and did another 8-week period doing the other treatment. And they had multiple endpoints. Their primary endpoint was using the Epworth Sleepiness Scale, and secondary endpoints they had like preference, usage, sleep architecture, and like the quality of life. So this brings us up to like the first thing on their inclusion and exclusion criteria, and wanted to know what you guys thought about it. So adult patients over the age of 18. One thing that we always talk about positional therapy a lot, but they had this criteria for it where if they had a total above 5, basically the supine to non-supine ratio had to be basically a 2-to-1 on the diagnostic PSG. So I thought that was a good way of distinguishing it, because a lot of times we do know that like they do get worse on supine, but it's only a mild increase. And they did use more of the modern AHI criteria cutoff, where it's above 5 and less than 30. And then do you guys think it was sufficient amount of time with the minimum 30 minutes of total sleep time in the supine and non-supine position compared to what we like do in our current clinic?
Not enough time.
Yeah. So this will actually play a good part in later on like what they like you'll see in some of the results. And then they used an Epworth Sleepiness Scale of greater than 10 as their cutoff point to test patients. And then some of this is like willingness to do a lot of the questionnaires, the neurocognitive testing, and if they could do the protocol and such. And then, do you guys have any issues with the exclusion criteria?
I don't have issues. I understand why they didn't include pregnant patients, though I do think it would be cool to see what would happen, given a lot of patients who are pregnant do technically naturally use positional therapy. So I thought that kind of would have been cool to see, but I do understand why they didn't include it. And then also for the hypoxemia, it should have been an exclusion, just like how they have done it, given that there's other confounding factors causing the hypoxemia, and that wasn't going to help, because if you do have hypoxemia, you might still have the daytime sleepiness, and that's what they use to kind of determine if patients had improvement in addition to the AHI for this study.
Thank you. And then they also included like all the other possible causes like alcohol, medication, drug abuse. Um, and then if someone was very severe, they didn't opt them out of CPAP, basically the urgent treatment. So this is how they initially started, which shows that they did start out with a lot. They had 2,774 PSGs performed between the year of like June 21st, like 2018 to like January 11th, 2013. And then this is the criteria that they took out based off like what didn't fit their criteria. So to sum up a lot of this, like if they didn't really have OSA, or the supine to non-supine AHI was less than 2, or they had hypoxemia, severe OSA or their criteria of less than 30 minutes on each side, they essentially only only 1,914 met the AHI above 5. And then like basically their positional therapy excluded a lot. And then only basically out of all of this, only 383 met the criteria. So it's already it went from a big number already to a small number based on their criteria. And then like the previous slide showed, they had a lot of exclusions. So if they're previously treated, they have to be treatment naive or insufficient symptoms like their Epworth sleepiness was less than 10. Sometimes canceled or lost the follow-up or declined to participate. And then, do you guys know what it means by missed? So the missed category was patients that, given that this span from 2018 to 2023, this missed categories were patients in between like a COVID period window where like possibly met the criteria, and then they started them on auto CPAP and didn't give them the option of positional versus like CPAP therapy with a titration. It was basically in the 2020 period. So from that, all of that, they actually started off with 64. And then out of this, they randomized into 32 to start with positional therapy and to CPAP. Do you guys think that was enough patients? To like get a statistical significance and such?
It doesn't seem like a lot, Isaac.
Yeah, it doesn't seem much. So we got from their website, the Australian New Zealand Clinical Trials Registry, that like they powered it to 50 to determine an adequate like 2-point reduction in Epworth sleepiness scale. Now, if they added other and then it was a non-inferiority way of analysis. So if they added other variables, it may have not been statistically significant, but I'll get into that too. So from this 64 in the end, they did this like crossover after 8 weeks, and then had a couple withdraw or unable to tolerate the therapy, and then ultimately they got to 52. So they technically did reach their 50 threshold. And this is just a better pictographic form of it, where half of them basically went to CPAP, half of them went to positional therapy. At 8 weeks at the clinic appointment, they filled out their questionnaire, and they switched off to the opposing side to see if there's any difference, and then after 8 weeks again, did the same thing. So now this gets into a lot of the bulk of how this lecture is about. So what do you guys think of the like baseline demographics, their initial PSG results, and like the questionnaires? And I have the second part of the questionnaires on the next slide. So this is just half of it.
There's a couple of questions in the chat, Isaac, if you can see them.
Oh, let me see.
I can read them if you can't see them.
No, I see them. It's just they don't pop up when on
Right.
this mode. So Dr. Kaplish, how did they assert the Epworth sleepiness scale attributable to positional sleep apnea? We were trying to figure that out from the New York registry. It was still kind of confusing.
I'm assuming that they did the Epworth at 10 just because they wanted those patients to have clinical care and not randomized into a trial, would be my guess.
Yeah.
But the inclusion criteria did say that Epworth of greater 10 is attributable to OSA.
Yeah, they did say that, and I was confused as well. And we went to the registry because it wasn't in the actual paper. How did they attributed it to positional OSA? It was kind of
I think it was the power analysis we went to the registry
Yeah.
for.
yeah, we went to the registry for the power analysis. They didn't really mention how they attributed it to positional OSA, unfortunately. And then the non-supine, yeah, it was very borderline. Because they needed to have that greater than 2, like times the difference. So in terms of it, we'll actually get to it in the next slide, Dr. Kalish. So in this slide, like basically a lot of people were around the age of 50s. The BMI was in the 30 range mostly, and for our demographic in the US, that may not be that applicable. They did have a good split between males and females. The only thing that they didn't mention is since this was a Australian-based study, like the demographics were essentially Australians over like what we have here, which is more diverse. And then their overall AHI was basically 15.5, which was borderline. I mean, like it's between the mild, like to moderate range. They broke it down to the supine and non-supine, and like Dr. Kaplish mentioned, the non-supine was actually basically right at the cusp of if we had night-to-night variability, what if it was lower or higher? It's hard to say. They had a pretty good distribution for the rest of it. And then the next slide actually had a lot more information, but a lot of this is compared later on, and like we'll see how that plays out. So this was a lot of the other stuff, and the more part that I wanted to focus on was a lot of the questionnaires that they did. So this was just based on like patients' medical history, smoking, but like their Epworth the median that they got was 12. This Pittsburgh sleep quality index, they basically measured using a 0 to 3 on a current like parameters like duration of sleep, sleep disturbance, sleep latency, daytime dysfunction due to sleepiness, overall sleep efficiency, sleep quality, and the need medications to sleep. And the maximum score was 21, but essentially over the score of 5 was considered with poor sleep quality. And then this one stands for Functional Outcome of Sleep Questionnaire. It's kind of used in research and better to trend, and they noted that like it's usually highly correlated and indicated ability to measure like meaningful change. So it's better to like get it like over time. The lower score is considered was worse apparently. And then they did a lot of the other ones that we see, like Insomnia Severity Index. And then does anyone know what this SF-36 is? I have to look it up myself.
The popular generic quality of life measure that can
Yes.
be used to compare different disease states.
Yeah. And they have a lot of these breakdowns, but I think a good way to describe it is the closer to like 100 usually means better quality of life, while closer to 0 is worse. And notably, everyone picked around medium or below. So a lot of people said their quality of life was essentially on the lower side. And then this DAS is essentially the scoring system was anywhere between, like, each one of these had a different scoring system, unfortunately, but basically, for depression, a score of 6 was considered mild. The anxiety one, 6 to 7 was kind of in the middle as well, and for stress, patients were like on the higher end. So one thing to note was a lot of patients did note that like their quality of life was on the lower end. So in relation to the results, and what do you guys think? So their primary endpoint was actually looking at Epworth Sleepiness Scale from baseline. And they said it was statistically significant in both groups. So a baseline of 12, they got both to 8 at the end of the 16 weeks. And this is their breakdown. And this one was more, I would say, straightforward. The other secondary at points were actually a little bit different. So I didn't write it here, but initially what they got was the positional therapy first. A reduction from baseline was initially a 2 and then 4 after 8 and then 16 weeks. And for CPAP, it was actually a little bit higher. They had a 3 reduction initially in the 8 weeks, and then when it was at the end of 16 weeks, it was 4. But at the end of basically 16 weeks, both of them were the same at 4 reduction. And this gets, I think the secondary outcomes are more interesting on this. So in patient preference, like I think most people may agree that maybe the positional therapy was easier and more comfortable to use. But they perceived CPAP as being more effective. And then I wrote this here because it was essentially almost a 50-50 split. 50% preferred CPAP and almost 50% preferred positional therapy, but that was because one patient didn't record a preference. But overall, there was no relationship between overall device usage and improvement on Epworth Sleepiness Scale. Like their p-value is on the not statistically significant. But when I get into a lot of the breakdown of the data of what they had, there's a lot of issues that come up. So they did a very simple questionnaire on how they wanted it, which was which device is easier to use, which more comfortable, which device you think treated you better, and which one you prefer to use. So this is the first one that has a lot of differences. So on treatment usage, they said there is the average daily usage was, they said no difference, but in terms of what insurance like in the US compared to, let's say, Australia, you guys see how much time they're using it for? It's like really not that high on average. 3.3 hours for both. And then they also did, what if one person had it on usage, like if positional therapy first compared to second? Like if there was any impact. And they said there was no impact on positional therapy first compared to second, but they did have a difference in time. But this one was different compared to CPAP, using it first compared to second. People used it a lot more, 4.2 hours compared to second. And then what do you guys think about the relation to usage? Like if they preferred one or the other? They actually had a questionnaire based on that. So people that preferred one or the other apparently used it more. And like CPAP had 4.1 hours compared to positional therapy 3.3, and then almost kind of similar the other way around. And then this was the breakdown in Epworth sleepiness scale that they had. And then this is just a picture of how they broke it down based on the arms of the trial. And I think most of you will be more interested on the PSG outcomes to see if there's any true difference. So for PSG outcomes, let's say if we had 15.5 as the initial AHI with positional therapy, they still had 7.7, but the problem is it crossed the threshold, and then CPAP, it was much lower reduction. And this was like the picture of how showing it. The only issue was this had a big margin of error, the positional therapy. And the next slide has a lot of the breakdown, and
I think the CI there is mistaken.
so we did discuss about it that this is what they had in the paper, and we think it was a mistake in the paper too. Like it
Yeah,
was,
it's a mistake in the paper.
yeah, that's what we were thinking. Good,
The
good catch.
CI, the,
We did see that. Yeah, it was kind of we were thinking this was also a mistake in the numbering. So this gets into a lot of these numbers. Do you guys see anything that's kind of an outlier in this? So in terms of variables, does it make sense that the non-supine AHI with positional therapy was higher than the baseline, even though you're using the device? They actually commented on this. One person marked that they like the device marked that they were sleeping supine the whole time. Like even though they were non-supine. So like they didn't pull out that outlier. It added like 119 minutes of supine sleep to it.
well, the other thing is, why is the CPAP on supine AHI for CPAP not better than 8.3?
Say that again, Dr. Shervin?
Why is the supine AHI on CPAP not better than 8.3?
Not better than 8.3.
Yeah. The third to the last column, second
Yes.
row of data, it says 8.3.
Yeah. It could be that they didn't change pressures after they put them on a specific value compared to positional therapy. I couldn't really find why they had an 8.3. A lot of these data points, it seemed it was based on a snapshot in time, and they just conglomerated a lot. Like they just pulled in all the data together. because it did because a big aspect was like it shows the supine AHI was better here. But there's also a good factor that it could be the time on supine compared to the time on supine with the positional therapy. This one had much more like data compared to the supine on positional therapy because most people adhered with positional therapy. And they actually wrote that it restricted the supine total sleep time to 5 hours and like about 30 minutes compared to the CPAP use. Or sorry, 5 minutes and 27
Yeah, I see.
seconds, sorry. Compared to the CPAP, which was 151 minutes, and they had this plus or minus 97 minutes. So it could be that they had a lot more time in the CPAP use compared to in supine compared to positional therapy. The sleep efficiency was a little bit better with positional therapy, but neither had
Yeah.
statistical significance.
Look at their wake after sleep onset. Almost 2 hours.
So compared to baseline, it went up with CPAP.
And still alive.
They need
Yeah,
CBT. CBT.
CBT.
And they got insomnia.
Yeah,
Todd is just reminding us that no patient should have positional therapy or CPAP without CBT.
That's correct. Yes. Or which order should they have it in would be the question here.
true. And then, but overall, a lot of these, there was a lot of outliers that didn't line up, but a lot of it could be due to timing of how they recorded it. Sleep efficiency kind of didn't really actually a little bit better on here, but only 3% and 4% lower in CPAP. But overall, a lot of them didn't have much, like other than a couple of less than 0.001, a lot of them didn't have much statistical significance. REM was kind of similar in timing to a certain degree. Like you said, the wake after sleep onset still remained high. Their arousal index, I think, is another big one that showed it was still mildly decreased, but overall their sleep efficiency didn't really change too much. Like let's say getting above the 85% for the insomnia. And then what do you guys think of this their breakdown of the actual other questionnaires? So for sleepiness scale, they did note at the end, positional therapy and CPAP was a 4% reduction. And that's where they got a decent p-value. But the Pittsburgh sleep quality index, they didn't get that statistically significant improvement. So only one questionnaire so far. In terms of insomnia, they did get some improvements, but it went below like right around 10-ish, but it has still had this margin of error that is kind of still in the range of where the initial baseline is, even though they got statistical significance.
Yeah, that's a small change. I'm surprised that's significant.
Yeah, so like statistical significance versus like actually clinically significant. And then in terms of their SF-36, like quality of life, there's really not much change. Kind of stayed the same. And it's even the DAS, even though it did have a reduction, by a couple points. It's not much, not too much of a difference, but some of it did look better compared to the baseline. So, what do you guys think about a lot of these quality of life measures? Because we do use a lot of different ones in sleep, and the question is like, will it change how we like think about this to a certain degree? Sorry, I guess I had the same slide twice. This was just a better pictographic form of the SF-36, which essentially didn't show much difference between all of them. And I'm gonna ask a lot more on the key findings on this one. One sec.
I think one thing just to point out is the duration of the trial as well, right? For some of these measures to change, maybe it wasn't long enough. Maybe they don't change, but maybe it wasn't long enough.
Yeah. So we'll get into it in the after this, the key findings one. So do you guys think this will change our practice based on the symptomatic improvements? Like they have mild to moderate OSA and it's saying the delta of the Epworth Sleepiness Scale, or there was no difference between the two therapies. So a lot of patients, sometimes we do give them options of what they could try. They did use a specific device that monitors like if they're on their side or on their back. But do you guys think this will change our practice of, you could say, trying positional therapy first? If the patient wants it.
I mean, technically, in my opinion, if you have a patient who's like borderline sleep apnea and they have like bigger concerns that you'd be more like, if you're more worried it's like a psychosocial issue or like more insomnia related, but they do just have a component of sleep apnea, I think positional therapy could be very beneficial in the sense that it's just one less thing that they have to like, worry about. For example, having a CPAP machine does take a little bit of stress on you. And so I think positional therapy could be beneficial, just as like an add-on component. And if nothing else, like Dr. Goldstein and I were actually just going over a sleep study where once the patient got in a certain position, his sleep apnea dramatically improved. So I think there is definitely a component where positional therapy could play a role.
Now, I'm assuming it's multifactorial. If the AHI reduction, both of them showed a reduction, but and the baseline of the non-supine was basically around 5. The question is like if let's say after the study, if it was a positional still had residual, even though it said 7.7, but that was the one outlier. Does it actually like if we omit that outlier, it probably went lower than 5 at times? Like the only question is how do we, it mentioned restricting supine sleep was a big factor. So if we could get patients to sleep on their side, it would maybe be better. Now, do you guys think the sleep efficiency, even though it was like mildly improved with positional therapy, really changed much, or could have been comfort of the mask, or like did it really have statistical even if it had statistically better sleep efficiency, like was it clinically relevant? probably since they had such a small number and it was only a couple percentage difference in sleep efficiency, it's hard to say if it really made a big difference. Now, their overall conclusion on patient preference and outcomes, they said no clinical significant difference in like the sleep architecture, usage, or overall patient preference. But like in the breakdown, it did show that there was a difference in terms of actual usage time. If you preferred one or the other, you used it over basically over 4 hours, but not like a big issue with the study was they didn't really use it over 4 hours, basically. Like, would it have a bigger change if they used it the whole night they were sleeping?
I think, let me ask you a question. Of all the patients with sleep apnea that you've seen this year and treated with CPAP, what do you think the average usage is per night?
The main issue is it's very, like I've seen very, like 5 hours possibly. Like a lot of patients are on the lower end.
5 hours would be pretty good.
Yeah.
If you look at data, look at all the trials, 3 hours is typical. When we looked at one point, it was 10 years ago, or I don't think it's changed, but we did a study where we looked at all the people, we looked at a sample of low hundreds of people who came through the sleep disorder center. And, you know, we looked to see 2 years later what was going with them. And we thought that we guessed in advance that maybe half would be adherent. And that's about what we found 2 years later. So, you know, you need a broad level of circumspection when it comes to adherence. My 2 cents.
So that does bring a question up is how do we increase the timing of these patients' use then? Because like if you basically it's still on the lower end and a lot of patients aren't 100% adherent. Like they did mention
I'm not
go ahead.
saying what we do in clinic is ineffective. We do things and we try to get their adherence up. I think maybe we do, but it's a problem for the field. Depends who you ask and where you are. You can ask Dr. Tu what she thinks coming from Mayo, where my friends there tell me, oh, they have much higher adherence than that. I don't know, but could be. Most places report challenges with adherence in their patients.
I think this brings up another point that like their study design was a non-inferiority to try to compare CPAP to positional therapy. So they were saying that it could be used first line alongside CPAP. I know an aspect about some of these patients is like the first time they're using something to open up their airway, some of them do say the pressure is an issue, and if they could stay on their side, the pressure is dramatically decreased. So this brings up to like, do you guys think it will actually change our practice? Like maybe we could use both at the same time, which we do mention to patients all the time. Like to try to, we do notice a change in their AHI when they sleep on their side compared to their back. And then we mentioned some of the limitations earlier. It was like the timing was on the lower end, but the question is if that's technically the average of how a lot of patients use these devices, like, are we gonna have a bigger improvement if, let's say, we try combination therapy? Like, it's hard to say. They did use a lot of questionnaires. I thought that was they were trying to distinguish a lot of like different strengths of different questionnaires. I thought that was decent. And then Do you guys have any questions on what do you guys think about this overall study?
I have a comment, Isaac. It's somewhat related to what you're saying. Do you know if sleeping prone has any effect on sleep apnea? Because we always mention, yeah, avoid supine sleep, sleep lateral. I think there might be some evidence that sleeping prone might help in like mild sleep apnea. Have you heard anything about that?
Um, they did compare this to actually a couple different studies. Um, I don't remember reading if they compared it to prone. One thing that may interact with people sleeping in the prone position is kind of their head positions, I would say. Because when we're supine, like we see that patients could have their head to the side and head forward, and sometimes that has a change in their overall AHI or like severity, depending on where they put their head position while they're supine, which could indicate positional therapy as being more appropriate to them. I I also was thinking about that in prone position, because like do patients stick their head straight into the pillow or do they stick it to the side? Because like most people probably stick it to the side so they could actually take in deep breaths compared to. So I'm assuming it has to do it's a similar concept to it, but I think it would be an interesting study too, Farouz, because what if there's a weight component with sleeping prone that is symptomatically improving compared to supine?
Yeah, I wonder that too. Cool. Thank you.
You're welcome.
Well, one thing that might be interesting is to measure someone's sleep apnea before and after they go to the space station.
The space station.
Yeah, and see when they're weightless in space and asleep, whether they have as much sleep apnea.
Yeah, that would, and then don't aren't the beds in space vertical too? Oh, if
I
I'm
don't know, but it wouldn't make any difference, I guess.
yeah. One of the limitations that they mentioned was like they understand that their definition of positional OSA excluded a lot of different patients. And they had some patients that met the positional definition, but their AHI was over 30 or had significant hypoxemia, so it actually limited their amount of patients in the actual study. They also had the issue with COVID-19 period, which actually made their recruitment and treatment protocols kind of difficult to also like implement properly.
All right, so Rose has a new career direction now, space sleep, I see. But look, I'll just say a few things. This is it's an interesting study. It raises lots of interesting questions. The question about the AHIs and the definitions, which you asked about, but we didn't talk about much. It's very good. It's a traditional definition of positional sleep apnea, the 2-to-1 ratio. But if you're using it for a study like this, you'd want to know, well, is it okay to have 29.9 as your AHI and then 14 as your or 29.9 when you're on your back and 14 when you're on your side, because if you're treated with positional therapy, you'll still have apnea if you believe that AHI is an important factor in that. So maybe a better definition would be 2-to-1 plus you don't have above 5 or 10 or whatever when you're lateral. But the other big elephant in the room is they didn't look at a range of outcomes. They looked at sleepiness. And somewhat at quality of life. It did look at quality of life, but there's a billion other outcomes we'd be interested in. We know from using esophageal pressure monitoring in studies that the problems are not just during apneas and hypopneas, that they're pervasive, that your airway closes and you're working harder to breathe during lots of all the other sleep. And they didn't study that. So I do think they are interesting data, and I think it does make me think more about positional therapy as an option. I don't think it makes me think of it as a first line option in most cases until we have more data about positional therapy. But I will say this has been studied for many years, and anybody who's interested should look at Rosalind Cartwright, for example, has published on this. I think she wrote a book where she covered some of this too. And so it's been an option in the field for a good while, and yet we don't have nearly as much data on this as CPAPs.
Well, before we end, just check the chat, Isaac, because there are just a couple more comments, questions in the chat if you haven't seen it.
Yeah, the lab and sleep efficiency is not accurate. That I'm glad someone mentioned it. The adherence is a problem everywhere. And how much how the positional therapy would possibly be covered by insurance. Yeah, so that's a couple things that like we know the sleep efficiency in a lab is not like home. So I wonder if they like did this with a home sleep test, it would be better. It's hard to say because it may miss certain stages and such, and we can't monitor the actual stages. The adherence, I agree. And then that's another big component. Will insurance cover a positional therapy device? Which, as far as my limited experience in sleep so far, is we always, tell them, hey, there's these positional devices on Amazon and such like that. So I'm wondering if they would actually cover positional devices as a way of at least partial treatment. Because this gets into the other category of dental devices sometimes having an issue getting coverage too? I'm actually gonna stop sharing. And does anyone have any additional questions?
Yeah, just going back to what we talked about earlier about the type of trials. So to point out that, Isaac and I did go back and look at their clinical trials listing, and in there they do talk about it being designed as a non-inferiority trial, right? So typical trials will be superiority trials. We're going to design this, treatment, we're going to design this study to see if this treatment is better than the other treatment, whereas this one was not designed that way, and that changes things a little bit. But if you look in their, I think in their methods, they talk about equivalence, which is yet another type of design, and it does change the statistics a little bit. So I think just keep that in mind when we're looking at these studies, is how they actually design them, because depending on what you read here, it could be one, it could be the other. They weren't particularly clear, actually. So the reality is, how did they actually do it? But just to point that out, not really for discussion, just to point it out, because we are.
No, it's helpful because I didn't read it as a non-inferiority trial because I'm used to seeing non-inferiority margins between
exactly
two treatments, and they really didn't give you that. They just gave you I assumed it was not a non-inferiority trial. But
yeah, so they did not present it very well in that context. Yeah. All right, everybody, thank you. We ran over a little bit, so thank you for hanging in. And thank you, Isaac, for presenting.
Hey guys. If you heard snoring in the background, it was this little guy. So I'll talk to you guys. I'll see you guys later.
All right, thank you.
Bye. Bye.